Hello, everyone. We are so glad you joined us today. And we are bringing a little piece of NTI 2026 to you here. It was too good to leave in NTI and to leave in San Diego. So we just wanted to record this so you would get a little piece of that for you here today. We are going to be speaking about no guesswork in a crisis, safe line labeling, and hemodynamic monitoring. I'm super excited to be co presenting with Amber Hinton, and she will share her disclosures in a moment. But I am Angela Craig, and I work full time at Baxter, and I am a senior medical manager with Baxter Medical Affairs. I still work at the hospital one day a month. I just can't quite get away. I am a clinical nurse specialist, and I am on the advisory board for Sepsis Alliance.
Hello, I'm Amber Hinton. I am a clinical nurse specialist from Indiana. I primarily work at IU Health and I support the critical care spaces. I am a consultant for Baxter and I am being compensated to assist Angela with this presentation. We can start with our objectives for today. We're going to describe current guidelines for safe intravenous tubing labeling, as well as discuss how labeling technology can be used to improve patient safety.
And then I'm going to come in at the end and explain some key levers of perfusion. And we are going to apply a case study approach to incorporate stroke volume guided fluid management into daily practice. And you are in for a treat to hear Amber speak with you today.
All right, so let's kick it off and talk about technology promoting safe medication administration. So we know as critical care nurses, intravenous medication administration is something we do on a daily basis. It's a common practice, but doesn't come without a high risk. So, the Agency for Healthcare Research and Quality tells us that medication administration errors are prevalent in an estimated median error rate of 8 to 25%. But the astounding thing is that IV medication administration is even higher of that percentage for 48 to 53%. And these errors can be things like titrating outside of your orders at a more frequent rate, or perhaps administering more volume than intended. The Joint Commission reports that an incidence of medication errors in acute care hospitals is approximately 6.5 per 100 admissions. So think about what that impact would be in your daily practice. To prevent medication administration, we have for some time been using low tech solutions. We know communication is super important in the healthcare system because it's complex and multiple disciplines are involved in one medication administration. So, our pharmacist colleagues ensure that we are using something called tall man lettering, right? So you don't get those medications like dopamine or dobutamine confused. So they make certain letters within the drug title larger to draw your attention and ensure that you're giving the right medication. There are also lists that have been compiled in a do not use list, meaning certain abbreviations we shouldn't use because they can cause confusion and really inhibit that communication that's so important to ensure that we're providing safe medication administration. Patient education. The more we can get the patient or their family member involved in the care that we're providing will stimulate those questions that will then encourage you to think twice about what you're doing, or encourage that critical thinking that could then possibly lead to a stopgap in wrong medication administration. Optimizing nursing workflow. So think about those times that you're in the med room in ICU. We use it as a safe space, right? Because we're the only ones that can get in there. So perhaps it's you and a colleague that are decompressing about an event that you just had. However, though it may be a safe space, the medication room should really be an area where you're devoting clear focus to the task at hand. So I know that I've worked in a facility in which um, we've posted signs of occupancy of one in the medication room, right? Just to encourage that one nurse should be in there at a time so that sole focus can be given to um, retrieving the intended medication so you don't grab the wrong thing. Also, there are things like independent double checks. So those super high risk medications, we force function through our electronic medical health record that another nurse needs to come behind and do those 5 rights of medication administration to ensure that the pump was programmed appropriately and the right medication is being given to the right patient. But as time has moved on, like, we now have some high-tech solutions out there. I remember when I started practicing over 20 years ago, we did not have barcode scanning. So that is a nice second check to ensure that we're scanning the right patient, we're scanning the right drug. So we're giving the patient the medication that's intended. Um, we also now have smart infusion pumps that are interoperable with our electronic health record. So we're ensure it's just another safety check that also helps facilitate documentation. So, the Joint Commission has standards for safe medication administration, and there is a national performance goal for effectively managing medications. And really, what they're saying is that all solutions on or off the sterile field in a perioperative or procedural setting should be labeled appropriately. So, how does that impact critical care? Well, we very frequently turn our critical care rooms into a procedural setting, right? We do bedside procedures daily. So, that is suggesting to us that all medication labels should include name, strength, the amount of medication, the solution, the diluent name, the volume, and the date and time of expiration. That's a lot to fit on a label and time consuming, right? Because usually the procedures we're doing in the critical care space are of the essence, right? They're typically not planned always, right? So we need to ensure that we get that medication labeled appropriately. Um, to ensure that the patient receives the correct medication at the correct time. So, any medication that we're not giving immediately really needs to have those labels on it. So, think about that time in which you do rapid sequence intubation. And usually there's a kit, whether it be virtual or in a bag, that the nurse is able to use. But in that, you get multiple drugs and you may not be using all of those. So, really important, or you might be giving multiple doses. So, really important that we're labeling those syringes in that moment to ensure that we're giving the patients the right medications. So let's look at the Infusion Nurses Society standards of practice. They provide us guidelines for safe IV infusion administration. And a few things I want to talk about is tubing management. Um, we know that the latest guidelines that came out in 2024 speak to discarding the IV tubing after 7 days. Um, outside, those are your normal infusions that you have. Now, we know that we have blood products and medications that contain lipids or TPN that need to be changed more frequently. Um, but they also suggest that intermittent IV tubing should be changed every 24 hours. So when you think about what does that look like in implementation in the critical care setting, that is a whole lot of labels flying around because we are given intermittent medications for electrolyte replacement and antibiotics. We do that frequently every day. And so changing the tubing every 24 hours for those drugs, but yet having a separate process for those continuous infusions can get confusing. Um, so we want to ensure that those IV tubing labels also include all components. So that's the date and time the tubing was hung, as well as the date and time the tubing is set to expire, the medication name, as well as the route. Are you giving it in a central line? Are you giving it in a peripheral IV, right? Because we don't want to interchange that and put the patient at risk for a central line associated bloodstream infection. So those labels should really be at the patient access as well as at the connection to the solution container, meaning where you're spiking that tubing into the drug, there should be a label there for ease of staying organized, understanding what you're hanging and when the tubing needs to be changed. So ISMP tells us that we should be using auxiliary labels. So it's highlighting the risk of a drug. For instance, ganciclovir, a hazardous drug. We need to make sure that it is perfectly clear to the nurse that you need to take extra precautions with this drug. So typically you see like a hot pink or a hot yellow label indicating, hey, this drug is a little risky and you need to protect yourself as well as the patient from this. But also keep it organized, right? We, as ICU nurses, we love to be organized. And so making sure that those tubings are not, you don't have one in channel A running clear to the right to a drug and crisscrossing. Keep it organized so that it's safe for the patient. And you always want to follow the tubing from the medication to the patient to ensure that if you're removing something and flushing, you know what you're flushing. Do you need to do a waste before you do that? So let's switch gears a little bit and go into how does this impact preventing hospital acquired infections, right? Because safe medication administration and components of that we discussed, such as changing your IV tubing when appropriate, really does have a big impact on preventing hospital acquired infections. So, what is a central line associated bloodstream infection? The evidence tells us that if we follow the specific components of a bundle and ensure all interventions are in place, that we can prevent a secondary hospital acquired infection. And for this presentation, we are going to focus on IV tubing and dressing change labels, right? Because those are super important and we have technology that can help us with that. So, just a little sneak peek at some of the latest evidence and what's going to be coming to your practice soon is, has anybody heard of a catheter associated bloodstream infection? So, we are broadening that scope of what we're looking at with how IV accesses can impact or cause bloodstream infections. So not only will we be focused on those central lines, but we are looking at all vascular access moving forward. So a CABZ or catheter associated bloodstream infection is still in the works, right? There's not a standardized definition currently. And we're not reporting this as a CMS requirement. However, we know it's a best practice to keep our patients safe from all bloodstream infections. So, our colleagues at APIC have developed this implementation guide for our infection preventionists to use to start the conversations. And there is a working definition, and you'll notice that it looks similar to that of a CLABSI definition, and that a vascular access device needs to be in place at the time of the onset of infection or the day before, and it needs to have been in place for at least 2 calendar days. So just think about that. Take that little nugget back to your practice. Just to have extra precaution in every access you're doing with um, peripheral vascular access. So now that we know why to label, how do we achieve consistency? So I'm sure a lot of these photos on the screen are resonating with you. You've seen these, right? So labeling IV tubing is a task that we know is time consuming. It's labor intensive and it is a manual process. So this has not changed in over 20 years. We've been trying to use these colored labels in a way in which it would help us succeed in the implementation of labeling IV tubing. But no matter the implementation techniques that we've used, we've still failed across the board to be consistent in ensuring that our IV tubing is labeled appropriately. I want you to look at the picture in the bottom left-hand corner. That was taken directly from one of the units that I support. And you can see that there is silk tape used at the patient access and a permanent marker being used to try to label what drug is infusing at that access. Um, and they're doing the best with what they had before we switched to utilizing technology. So is that handwriting clear? Maybe to some, maybe not to others, right? And then if you look at the label in the bottom right hand corner, it says IV tubing changed. And then it says date and hour. Does that mean it was the day it was changed or the day it's due to be changed? That can be interpreted differently, and it goes back to that communication. So now we have technology that supports making medication administration more safe for the patient, right? So we know why to label it. So why not label it when you have a technology that can help facilitate meeting all of the recommendations from Joint Commission, from ISMP? The guidelines that we have out there are supported by this technology to help ensure you have all the components of the medication label to ensure that we are streamlining nursing workflow as well as promoting safe medication administration. So, what does technology into practice look like? So, IV labeling technology has granted us the ability to quickly and efficiently label both syringes and IV tubing. So, you can see on the right, the syringe label gives all of the components necessary to ensure the nurse is going to give the right amount of the right drug to the patient. We see there's a place for medication alert. That's where you can see if it's a vesicant or a paralytic. We have the drug name, the diluent, concentration, dilution, who prepared it, and when it's due to expire. On the left-hand side, the middle picture shows you the IV Verify label that is printed that provides you three different labels in which you can label your drug under the drip chamber. You can label the name of the drug below the IV pump and then label the drug name at the patient's access. So, making it super easy and clear to see what is infusing and when it's infusing. Now, let's look at clinical outcomes. Um, how does IV technology impact the CLABSI bundle compliance? So, in August of 2024, a unit that I support had their first CLABSI in over 6 years. So, they had that central line associated bloodstream infection. And anytime we have a patient that endures harm under our care, we do a deep dive into the care of the patient. And what I found was in maintaining the CLABSI bundle, the different interventions, we were maintaining consistency within the audits of 95 to 100% the majority of the time. The outlier was the IV tubing labeling. So, despite having labels in the room, having a process in which we were supposed to stock the labels and the nurses were to label the IV tubing, we still were not meeting that metric. So, I discovered this technology that could possibly help my nurses be more efficient and be effective in obtaining compliance within this CLABSI bundle metric. So, when I piloted this, I really wanted to look at Does the technology have more impact if it is put at the point of care in the patient's room or in the medication room where the nurses will remove the medication? So, we did what's called a split trial. So, we have 12 critical care rooms, and six of them had the IV Verify technology in the room at the point of use, which the nurses were used to in their day to day workflow. And the other six rooms were supported by the IV Verify technology in the medication room when they removed the medication from the Pyxis. And what we found is that if at the point of use, the nurses were able to obtain 96 to 100% compliance with IV tubing labeling. And this continued. You can see the top graph. This continued clear through quarter two of 2026. So that's that sustainment piece. Not only was it effective during the trial, but we have been able to maintain for almost 2 years having IV tubing labeling compliance greater than 96%. What we found in the rooms that were supported by the one IV Verify technology printer in the medication room is there was improvement in the IV tubing labeling, but we still were not able to achieve that greater than 95%, which was the goal we set out for. So we have not had a CLABSI since we instituted this IV Verify technology. So, what do we know about the technology and improving outcomes? IV device technology is an innovative technology that has helped improve efficiency in labeling IV tubing, improve proficiency in the nursing workflow. It's increased IV tubing labeling compliance. It's impacted our infection rate as well as impacted safe medication administration compliance. And now I'm going to hand it over to Angela, and she's going to talk to you about dynamic assessments, perfusion, and precision.
And Amber, before you go off camera, did you find that the nurses felt like this was easy to use? Excuse me. And were they happy about the change? Or, sometimes as nurses, I am one, sometimes we can be a little skeptical of change.
Yes. So, like with any change, it was implementation matters, right? So, how you educate, how you communicate. So it was a little bumpy, I would say, for maybe the first 2 weeks of the trial. But then, as all nurses, right, are required to float and help out in other units. And when they would leave the unit to help out elsewhere, they would come back and say, they really need to get these printers. So then they found not having them was a disruption to their workflow. So I think I can say from the surveys I provided to my nurses and the feedback that I got that they love the printers, they love utilizing technology, and they are kind of upset when they have to work without them now.
Well, and as a fellow clinical nurse specialist, anytime we change things up, it's nice when it's perceived as a good thing. Sometimes we're perceived as people who cause more work for them. It's for the right reasons, right? But in this situation, it may be an extra step, but it's really not because we should already be doing it, right? So it gives them the ability to do something a much easier. And then that's always a nice thing for us to do. It seems like sometimes the things we implement have to be a little bit harder, but this was sounds like was a really nice implementation for you guys. Well, thank you for your presentation. I'm going to continue on with precision, perfusion, and dynamic assessments, getting fluid and drugs right. When we think about why fluid is important, I think of that Goldilocks principle. We don't want to give too much, we don't want to give too little, we want just the right amount. And as you can see here on this slide, that too much fluid is problematic, tissue edema, organ failure, etc. And too little fluid is also problematic. Tissue hypoperfusion, tissue hypoxia, organ failure. And we really want to get that sweet spot, right, where we have optimal fluid. And one of the things I wanted to share with you just is in regards to ultrasound IVC collapsibility. Now, there's a place for this for sure. And ultrasound is really an important part of our intensive care, and sometimes they even take it out to the floors, I'm sure, to help with assessments. But I want to remind everyone of the limitations of inferior vena cava assessments. So accuracy is better in the ventilated patients than in spontaneously breathing patients. A negative test cannot exclude fluid responsiveness. So what I want to tell you is that fluid responsiveness is different from a wet dry assessment. Our patients may be dry or may appear dry, but they may not have the ability to respond to fluid. And we'll talk about that a little bit more in a moment. But it is good for that wet dry assessment. And there's an average sensitivity and specificity, sensitivity of 75% with specificity of 83%. And we can do better than that. When you look at the response to passive leg raising, when we look at the changes in cardiac output, and we also are looking at stroke volume, you can see here that the sensitivity and specificity is much higher when we use a stroke volume or use a cardiac output assessment. And as I mentioned about the sensitivity and specificity of and on the previous slide, you can see here that the response to passive leg raising, when we look at cardiac changes in cardiac output and stroke volume, you can see the sensitivity and specificity is much higher. So we really like to encourage the use of stroke volume guided fluid management so that we can get it really close to being accurate. Now, I think there's real synergy in both. If you have a patient who you do your wet dry assessment and they appear dry, then you do a fluid responsive test that we're going to talk about in a moment. And we can determine if their heart is able to accept and receive fluid at that time to help forward flow and improve perfusion. So these dynamic assessments are done one of two ways. We can do a passive leg raise, and with our passive leg raise, you can see here we do a baseline, and that's where we're really calculating over about 3 minutes to determine what that patient's baseline stroke volume index, stroke volume is. And then and we attach them to technology so that we can assess that non invasively. And then the machine will tell you when the patient's ready to lay flat. We lay the patient's head of the bed flat. We lift their legs passively, and that volume that's in their lower extremities goes back and tests that left ventricle very quickly. And so we're able to see if there is a 10% or greater improvement in stroke volume. If there is, then that means that patient is fluid responsive. That means that that patient's heart at that moment can take and receive that volume to help forward flow and improve perfusion. Now, on the next part of this slide, you can see the bolus. So you can also do this test with a small fluid bolus. What I like about the passive leg raise is that it's reversible, right? When we have our patients laying flat and those legs are lifted, if they're not responsive, we can quickly lower their legs, lift their head, and that volume goes back to their lower extremities. But there's going to be some patients who can't tolerate that. So we can give a bolus challenge. Now, this bolus challenge is not we're not giving them, this is not the fluid they need necessarily. It's a small test to determine if this patient is fluid responsive. So we can see if their heart can take and receive this volume to help forward flow and improve perfusion. I know I'm repeating myself a lot, and I'm doing that for a purpose. So you understand why we're doing these dynamic assessments. So you can see here with the bolus, we'll have a 3-minute baseline. We don't have to worry about position. Whereas with the passive leg raise, when we're doing the initial assessment, we're getting that head of the bed up as high as we can to pull that fluid down to their lower extremities. However, with the bolus, as long as we keep that patient in the same position, we should be good. So we're going to just keep them in the same position, connect them to the technology, do a baseline, and then we are going to challenge the heart. Now, when I say challenge the heart, I'm thinking back in the day when we used to give fluid boluses, when you put it on a pressure bag and get it right in. And that's what I'm talking about. This is not 999 on the pump, right? So we are giving 250 mils in less than 5 minutes or 500 mils in less than 10 minutes. Very similar to when we're lifting those legs and it slams back to the heart. We want this to just slam in the heart so we can determine if they're fluid responsive very quickly. Once again, that golden number is 10% or greater, means you're fluid responsive. Now, I want to mention here too, if the patient has a high percentage of change, for instance, if they're 50% fluid responsive versus a patient who's 20% fluid responsive, that does not necessarily mean we give the patient that's 50% fluid responsive more fluid, right? It just means they're fluid responsive. And hopefully more studies will be done in the future to where we can really determine why some patients are 50% fluid responsive, some are 30, and some are 20. So, in this study by Benser et al., the question was, will this hemodynamically unstable patient respond to a bolus of intravenous fluid? Did you know only 50% of patients are fluid responsive? Only 50%, I should say, of these hemodynamically unstable patients are fluid responsive. So, what that means to you and I is that only 50% of patients may benefit from additional fluid resuscitation. Now, let's be real. How many of you, when your patient becomes hypotensive, grab fluid initially? Let's be honest, it happens in my ICU a lot as well. Do we want to be more specific though? Because if we know that only 50% of the patients may benefit from additional fluid resuscitation, that means that 50% of the patients won't benefit from additional fluid resuscitation. Kind of a scary thought, isn't it? So let's talk about three levers of perfusion. And let's talk about how technology can help us with these decisions. And then we're going to do a quick case study. So, when I like to think about these levers of perfusion, we all should know that it's all about perfusion. That's what we want for our patients. We want them to be perfused. And pressure is just that, it is pressure. Pressure does not equate to flow. When we think of more flow parameters, I'm thinking of things like cardiac output and stroke volume. And the first lever of perfusion is preload. And I like us to think about stroke volume. Think V for volume. Normal is 60 to 100 mils per beat. Okay. Think of normal heart rate, 60 to 100. We would perform a dynamic assessment to determine if this patient is fluid responsive. And remember, what is that golden number? I hope you said to yourself 10%. That's right. 10% or greater means that patient is fluid responsive, which means their heart at that moment can take and receive the volume to help forward flow and improve perfusion. Our next lever that we can get from technology is afterload, looking at total peripheral resistance and total peripheral resistance index. Now, think R for resistance. And you may say, I've never heard of TPR before. I've had people say that to me. So, TPR is that surrogate. It's the non-invasive surrogate for SVR. So when we're looking at systemic vascular resistance, CVP is in that equation. Since this is totally non-invasive, we don't have to have CVP in the equation. So this is a non-invasive surrogate. Same exact normals as what SVR is, 800 to 1200. And the thought is the lower the number, the more vasodilated the patient, the higher the number, the more vasoconstricted. So as you give pressors and you increase your pressors, you should see an increase in this TPR number. And then we have our contractility lever. Cardiac output, cardiac index, think C for contractility. And if it's low, we always want to ask why. Is it because we need fluid? However, if we've done the preload assessment first, which that's usually what I like to do, then we will know if their heart can take and receive that fluid. Or if it's continually low, maybe that patient might need an inotrope, or do we need to check an echo? All right, so we are going to get right on to this case study. And this was the male nurse attending NTI in California, in San Diego. And we're going to name him Parched Pete. He is 5 foot 10 inches, 275 pounds, and he arrives in the emergency department after spending the evening at a local bar, catching up with his fellow nurse friends, of course, after all the sessions were completed for the day. But he does have some nausea and vomiting. He states he ate a piece of chicken that did appear a little less than cooked, and it was not at the restaurant that we had the dinner event at. He begins running a fever, and they anticipate that he has food poisoning, so they decide to do a sepsis screen and start some IV fluids. Now, based on Amber's lecture, what should we do after we start the IV? And after we hang the IV fluids? I hope everyone said a resounding label the line, right? Yes, we must label the line. So we're going to go ahead and label the lines here, just like Amber taught us. And this patient did have a known or suspected infection. He had 2 or more SIRS criteria. His white count was up to 15,000. Heart rate was 110. Respiratory rate was 22. And he had a fever of 101.5. His mean arterial pressure did drop. That was his organ dysfunction. And so the sepsis bundle was started. They gave a 30 ml per kg of balanced solution. Blood cultures were obtained. They gave a broad spectrum antibiotic. And the lactic acid was drawn, which was 2.1. And just as an extra, they went ahead and connected the patient to the non-invasive hemodynamic monitor to assess for fluid responsiveness. It's a great suggestion. Let's get it right in the emergency department. So when Pete was placed on the non-invasive hemodynamic monitor, you can see his results. We already talked about his heart rate and his blood pressure, but his stroke volume was 44. And so what is normal stroke volume? Hopefully you've said out loud 60 to 100. And his TPR was right at 800. That's the low normal. Remember, 800 to 1200 is what's normal. Cardiac index is only 2.0, and cardiac output is 5.0. So our question is this patient hypotensive or hypoperfused? And the answer is yeah, right? He has a low mean arterial pressure. So we are going to do either a passive leg raise or a quick little fluid bolus. Once that was done, you can see what happened. We went from a stroke volume of 45 to 50. And so that was a 12.2% fluid responsive. My question to you, is that fluid responsive? Hopefully you said yes, because it is greater than 10%, right? 10% or greater means the patient is fluid responsive. All right, so what do we do? Well, if they're fluid responsive, let's give some balanced crystalloids, right? Yeah, so we go ahead and we give some fluids. He was given a 500 bolus of balanced crystalloids. Blood pressure did improve, but 30 minutes later, this occurred. So the heart rate is still high at 128. MAP went down to 48. Stroke volume is only 52. TPR went down to 720. Remember, 800 to 1200. So is this patient more dilated or more constricted? We're more dilated, but our cardiac index is okay. Is this patient hypotensive or hypoperfused? Yes. So they deserve a fluid responsive test. Now, just know this, patients go in and out of fluid responsiveness, right? So you can do this whenever you're at that point where you need to make a decision, right? I highly recommend that you repeat that passive leg raise or the small fluid bolus. And so you can see here, after we did this passive leg raise, you can see here that our blood pressure is still low and our stroke volume only increased by 2. So you can see that's only 3.8% fluid responsive. And by the way, you don't have to do the math. The device will do the math for you. So what do we do? Since we had a patient who was dilated, not fluid responsive, and they were hypotensive, we started a pressor. All right. So we started a pressor, and Parched Pete was on Levophed. It seems to be working. His blood pressure improved. However, is there anything else that we should be worried about? You can see here that the mean arterial pressure is better. However, stroke volume is still very low. TPR is very high. We've clamped this patient down, and cardiac index is very, very low. So we do a passive leg raise or a small fluid bolus. And what do we find? We're only 6.7% fluid responsive. Now, what I want to say is for a lot of us, as we give pressors, if we are not monitoring hemodynamic monitoring, we would think, okay, heart rate's only 102, my MAP's up to 68. Yay, I'm good. But when you look down, isn't that scary to know that your patient's cardiac index is so very low? And if you didn't have this patient on a monitor, you may not realize that now it's a contractility issue. Yeah. So what do we do? Well, in this scenario, we're going to start an inotrope. The patient's cardiac index is way too low for that patient. So the fabulous nurse started the inotrope and continued to utilize stroke volume, cardiac output, and cardiac index and TPR to determine if Pete needed a preload, afterload, or contractility support. The nurse continued to stabilize the patient, and after 5 hours, patient has received more fluid based on stroke volume guidance, and nurse was able to discontinue the inotrope and is working on down titrating the vasopressor. So this is the result of utilizing precise care for Pete. You can see here that heart rate is 78 now. The mean arterial pressure is up to 86. Stroke volume is now 78. TPR is much better at 1127. And that cardiac index is up to 2.5. So I hope you've been able to see how utilizing stroke volume guided care can help to manage the patient. And I want to remind everyone that we do have a medical education website. There's nothing sales on here. You can scan that QR code. This is all about education and learning, and we will have this up on this website very soon, as well as we also have a lot of other podcasts and webinars on this site. It does ask you to state if you are a healthcare provider or a healthcare professional. So if you can just select if you are one, and then it will take you directly to the site. And I hope you enjoy that site. We have lots of references from what we discussed today. So we just want to thank you for attending today. And on behalf of Amber, her email address is ahinton@iuhealth.org. And my email address is Angela_Craig@Baxter.com. We are so glad you attended today. There is a short post-event survey that if you would take a moment and scan that QR code and just fill out those few questions for us, that would be greatly appreciated. I just want to thank Amber for co-presenting with me, and I hope you guys all have a wonderful day and have enjoyed this presentation.